Thank you, Jesse. Well, it's interesting. We're talking about opioids and bad science that leads to bad conclusions. Well, the same thing kind of happened with hormones, and I'm going to talk about that a little bit before I get into the actual science of it. So, women go through menopause, and men go through andropause, or menopause. But the difference is, women have an abrupt transition where they have ovarian failure. And they don't produce estrogen, they don't produce progesterone. And from the ovary, they don't produce testosterone. Now, they still produce testosterone from the adrenal gland, but it's in lower levels, much lower levels. So, what happens with women, and what is the role in pain in terms of pain management in women in menopause? Well, they suffer from hot flashes, and they don't sleep well at night, and night sweats, which causes them not to sleep well at night. Insomnia and sleep disorders, which we know is related to the lack of progesterone. I'll talk about that a little bit. Poor memory and concentration, more frequent UTIs, vaginal dryness, painful intercourse, loss of sexual desire, fatigue, depression and anxiety, mood swings, headaches, pain. They have more pain, right? And increased visceral fat. And we know that increased visceral fat, where we all get it around the belly, leads to insulin resistance. It leads to dyslipidemia. So these are all the things that are beneficial when we replace hormones. Now in men, the same thing, a little bit less, but they get loss of sexual desire, erectile dysfunction. They also get insomnia and sleep disorders, mood swings, loss of muscle, increased visceral fat. We all get a little fat around the belly, right? Yeah. Fatigue, depression and anxiety, headaches, pain, joint pain. And if it's extreme, we're at extreme loss of testosterone, we get hot flashes. Anyone know why that happens in men? Anybody? So it's related to the loss of estrogen. And men get their estrogen from testosterone. Testosterone aromatizes into estrogen. And men need estrogen just like women need estrogen. They need estrogen to keep their bones strong. They need estrogen to lower the risk of cardiovascular disease. And they need estrogen to lower their risk of dementia. So what actually killed hormone replacement in women? This is a very interesting story. It's important to talk about this before I talk about the benefits. And we're going to talk about what was called the Women's Health Initiative. Does anyone know about that at all? It's unlikely that you do. But what happened with hormones is kind of what's happening with opioids right now. The pendulum has swung too far. And there was a study that was instituted by the National Institutes of Health. It was in 2002. It is a $625 million study. It actually ended up being a $1 billion study. And the study evaluated the risk-benefit ratio of hormone replacement therapy in relation to heart attack, stroke, breast cancer, pulmonary embolism, colorectal cancer, endometrial cancer, hip fracture, and death among women. There were 161,000 women that were enrolled in this study between ages 50 and 79 at 40 clinical sites. 61,000 of those women were enrolled in the clinical trial and 100,000 in the observational trial. But actually what happened due to dropout, the actual number of women in the hormone trial turned out to be 20,347 women between age 50 and 79 years old, and they had three groups. They had group one that consisted of conjugated equine estrogen, which is Premarin, and medroxyprogesterone acetate, which is Provera, synthetic hormones that are produced from the urine of pregnant horses, okay? It's not the human bioidentical hormone. And group two was conjugated equine estrogen, or Premarin, and hysterectomy. So they didn't give progesterone because the thought was you don't need progesterone if you don't have a uterus, because you're not countering the stimulatory effects that estrogen has on the endometrium. But women have breasts, at least most women have breasts, and they still need progesterone. But anyway, this was group two. Then there was a placebo group. This was initiated in 2002. Now, what's interesting is that when you actually look at the number of women, 74% of the women in the Prem-Pro group and 76% of the women in the Premarin-only group were between ages 60 and 79. So most women had already been in menopause for more than 10 years, which means they already had pre-existing cardiac disease. Many of them did. They're overweight or smokers. So there was selection bias right from the start, okay? And what they did find, when they came out, there was a big publication after the findings. It made JAMA, headline news, estrogen and progesterone cause breast cancer and heart attack. And this reverberated across the world. So as a result of this, what happened? Women stopped using it. And they stopped using it, and a lot of bad things happened. But what the Women's Health Initiative actually found, and of course this was even faulty, that the real risk for heart attack was only in the first year. First year only. After that, the risk actually went down for heart attack. This was using synthetic hormones. And for a statistical analysis, for something to be actually valid, the hazard ratio needs to be above 3. Well, in not one of these outcomes was the hazard ratio above 2. It was under 2. So none of these were statistically significant. So let's just talk about heart attack. 3/4 of the women in the study were between ages 60 and 79, so there's already a selection bias. 70% of the women were overweight or obese, and 30% of the women were already treated with hypertension. They had pre-existing coronary disease. And the increased risk was only seen in the first year. We talked about that. And the risk became higher, actually, in the control group than in the HRT group after year 1. This was the initial findings of the study, okay? Now, in 2002, they published that, there was breast cancer risk, 20% increased relative risk of breast cancer in the Prem-Pro group, that's Premarin and Provera, estrogen and progesterone, synthetic, and it almost reached nominal statistical significance. Now, does anyone in their papers ever write almost? What the hell does almost mean? Well, almost mean that it really didn't, because it either does or it doesn't. But this was actually published. It almost reached nominal statistical significance. When they actually analyzed the statistics, the confidence intervals, if you all know your statistics, if they're appropriately adjusted, showed no increased risk in any of the outcomes. And the interesting thing, if you think about breast cancer, the time between initiation of breast cancer and the time that cancer actually shows up is 10 to 20 years. So, how the hell do we know? Because the study didn't last that long. It only lasted 7 years. And there's a difference, obviously, between breast cancer incidence and detection. And actually, in the Premarin group, it's the estrogen group only. Breast cancer incident was decreased. Okay, in the estrogen-only arm, synthetic estrogen, it was decreased. So Bernadine Healy, she was the physician director of the NIH, during the study, wrote a book, and in that she wrote, this was actually before the study, "To me, the benefits of HRT are nothing short of remarkable. Distilling all the reports, I conclude the long-term hormone replacement therapy may not make one feminine forever, but it clearly offers the chance for being healthier far longer. The benefits of hormone replacement therapy on individual diseases or specific organs are impressive, but when the benefits are looked at in aggregate, they are compelling." This is the medical director of the NIH study, which contradicted exactly what she said. So before the WHI and after the WHI, there are multiple studies that prove difference. 1986, National Cancer Institute said no statistically significant increase risk of breast cancer among women on Premarin, even those taking it for 20 years, in 1986. 1987, well-defined epidemiological studies of estrogen replacement therapy do not suggest an overall increased risk of breast cancer in postmenopausal women. 1988, Western Australia, no statistical association between estrogen replacement therapy and breast cancer. 1991, this was from Vanderbilt, no association between estrogen replacement therapy and breast cancer. 1991, Boston University, no increased risk of breast cancer among Premarin users even after 15 years of use. 1992, this is from NYU, after 2 decades, 11.5% of women on placebo developed breast cancer, and none of the women on HRT developed breast cancer. New England Journal of Medicine from Harvard, on the basis of the available evidence, we recommend that all postmenopausal women be considered candidates for hormone replacement therapy and be educated about its risks and benefits, 1993, et cetera. I'm not going to go through these, but over and over, all the way up to 2016, and this is a study with women who had the breast cancer gene, showed no increased risk for hormone replacement therapy. So how the hell did that happen? So now women are not getting estrogen and progesterone as hormone replacement therapy. Makes no sense. Let's talk about myocardial infarction. This was at Colorado School of Public Health. They studied a population of 63,566 women who were diagnosed with breast cancer at age 66 or older and followed them for 9 years. Well, what did those women die of? They died of heart attacks. They didn't die of breast cancer. So there was all this focus on breast cancer when most women die of heart attacks. They don't die of breast cancer. This is a study that showed that a white woman's cumulative absolute risk of cause-specific death from 50 to 94 years of age has been estimated to be 31% from coronary disease, 2.8% from breast cancer, 2.8% from hip fracture, and 0.7% from endometrial cancer. A consensus of epidemiological report has demonstrated that women who are given postmenopausal estrogen therapy have a reduction of about 40 to 50% in the risk of ischemic heart disease as compared to women who do not receive such therapy. So let's talk about osteoporosis. Osteoporosis results in fractures. Fractures result in pain. That's what you guys do. So we're going to talk about osteoporosis. You're not really focusing on prevention. You're just treating the problem, right? Maybe we should start trying to prevent some of this stuff. So worldwide, 1 in 3 women over age 50 will experience an osteoporotic fracture, and 1 in 5 men over age 50. 1 in 2 white women will experience an osteoporotic fracture at some point in their lifetime. Blacks and Hispanics have lower risk. Most commonly affected sites are hip, wrist, and vertebra. Combined lifetime risk for hip, forearm, vertebral fractures coming to a clinical attention is around 40%, equivalent to the risk of cardiovascular disease. Nearly 75% of hip, spine, and wrist fractures occur among patients 65 or older. And you guys remember that we're constantly remodeling bone. It's a balance between the osteoclasts and the osteoblasts. And when the osteoclasts win, we lose bone, and we become osteoporotic or osteopenic. Hip fracture, 75% of fractures occur in women and 25% in men. The lifetime risk of hip fracture is 1 in 6 compared to 1 in 9 in the risk of diagnosis of breast cancer. And hip fractures result in a mortality of 20 to 24% in the first year after hip fracture. Vertebral fractures are the next most common, 8-fold increase in age-adjusted mortality. They lead to back pain, loss of height, deformity, immobility, reduced pulmonary function. And a woman that has had 1 fracture is at substantial risk of having additional fractures. We use DEXA to diagnose it. We use the T-score. I don't know if you're familiar with that. In the yellow zone, you're osteopenic, and in the red zone, you're osteoporotic, okay? I do this on all my women. Any woman that comes to see me, they get a DEXA scan. because I can make their bone actually improve. I can show over several years bone growth, and we're going to talk about how we do that. And of course, how do we treat them? I don't know who treats those fractures. Anyone treat the fractures here? Andrea? So you can use vertebroplasty or kyphoplasty, right? Now, I'm going to start talking about the specifics here. The specific hormones and what happens. So this is with bone density. First, I want to say, people say, well, this is not FDA approved. Hormone replacement therapy is not FDA approved. Well, that's not completely true. It's approved for the prevention of osteoporosis, the relief of vasomotor symptoms, which are hot flashes, vulvovaginal atrophy that's associated with menopause. So it is approved for some things, not everything. And interestingly, the Women's Health Initiative study actually found a reduced risk of fractures in the vertebra and hips by 34 and 23%. This was in the study. Now, I'm going to go through various studies, and I'm just going to throw up some brief conclusions. Estrogen therapy in menopause is associated with a 60% reduction in the incidence of hip fracture. Women who initiated estrogen before age 60, which is around the time of menopause, and continued had the greatest bone mineral density, lost less bone, and experienced a 37% lower risk of fractures. Of importance, initiation of the use at age 60 or later is also effective in maintaining bone mineral density, slowing bone loss, and it appears to reduce fracture risk. So interestingly, estrogen will arrest any further loss of bone, but it won't make you gain bone. So I don't know how many of you are just taking estrogen only, but you ought to think about progesterone. Now, your gynecologist is going to say, well, no, because you can get endometrial cancer and you can get breast cancer, and the studies show this. Well, it's bullshit. That's not true. If you know the science, it's not true. This is from JAMA. The results show that postmenopausal osteoporosis is prevented or retarded by estrogen replacement therapy as compared with an unsupplemented control group. Medical sciences, long-term use of estrogen in appropriate doses reduces the risk of hip fracture by 50 to 60%, and the risk of vertebral deformation by 90%, or vertebral fracture. The ability of estrogen therapy to increase bone mass is enhanced. It's enhanced by adding androgens, which is testosterone, DHEA, calcium, supplementation, and exercise. We concluded that in postmenopausal women, treatment with combined estradiol and testosterone implants was more effective in increasing bone mineral density in the hip and lumbar spine than estradiol implants alone. Testosterone is anabolic, right? It's an anabolic steroid. It's anabolic to bone. That's why men need it too, because if you don't have testosterone, men, you're going to get osteoporosis, beyond other things. There's increasing evidence that estrogens are important in skeletal maintenance in men as well as women. Peripheral aromatization of androgens to estrogen occur in the osteoblast-like cells, and they can aromatize androgens into estrogen. This is in men. In men aged greater than 65, there is a positive association between bone mineral density and greater serum estradiol levels at all skeletal sites. How do we get greater estradiol levels, men? We get it from our testosterone. And how many of you have had your testosterone levels measured? Jesse? You have, right? I have too. And guess what? I'm on testosterone. I'm 56. Now, progesterone. Remember we talked about estrogen will arrest further bone loss, right? It'll arrest it. So wherever you are, it's where you are. If you got osteoporosis and you start giving estrogen, that's where you are. Conventional treatment with vitamin D, calcium, and estrogen will delay but not reverse osteoporosis. You heard? Let me repeat that. Conventional therapy with vitamin D, calcium, and estrogen will delay but not reverse osteoporosis. The hypothesis that progesterone and not estrogen is the missing factor was tested in a clinical setting and was found to be extraordinarily effective in reversing osteoporosis. You need to add progesterone to reverse osteoporosis. You stop doing this, you won't get fractures, you won't have pain, you won't see a pain doc, and you won't need a kyphoplasty, right? The finding that progesterone receptors is expressed at both the level of the mRNA and protein in several osteoblast-like cell lines, as well as human primary osteoblast cultures, indicates that bone-forming osteoblast cells are direct targets for progesterone action. Progesterone, which is P4, and estradiol, which is E2, estradiol's physiologic partner, collaborating with estradiol in every cell and tissue, its bone job is to increase progesterone receptor-mediated slow osteoblastic new bone formation. So if any of you gals have osteopenia and you're on estrogen therapy, you should think about progesterone. Melatonin. So I want to say one thing first about vitamin D. You know vitamin D is not a vitamin, right? You know vitamin D is a hormone. Because we get vitamins from our food. Our hormones are produced in organs. Where is vitamin D produced? In the skin. The skin's an organ. The sun hits the skin, cholesterol is converted by multiple steps into the active form in the kidneys. Vitamin D is a hormone. If you're low on vitamin D, you ought to be taking it because it's actually a hormone. Melatonin is the most potent antioxidant hormone in our body. It lowers your risk of cancer. It increases your intracellular glutathione level. Glutathione is the master antioxidant in the body. So melatonin is important. I tell all my patients to take melatonin, and I don't tell them to take it for sleep. I tell it to lower their risk of cell inflammation, inflammation at the cellular level, to lower the risk of cancers. So melatonin, through its free radical scavenger and antioxidant properties, may impair osteoclastic activity and bone resorption because we know that cellular inflammation increases bone resorption. We know that inflammatory cytokines will increase bone resorption. Additionally, melatonin may impair development of osteopenia-associated senescence by improving rapid eye movement and restoring growth hormone secretion, which we know is cyclical. It has a circadian rhythm, and growth hormone is anabolic, yeah? Melatonin has been shown at the cellular level and organismal level to promote osteogenesis and prevent bone deterioration, including preventing idiopathic scoliosis in adolescents. The mechanism by which melatonin protects bone may occur through its actions on both osteoclasts and osteoblasts through an interaction with estrogen. DHEA, see? DHEA is an adrenal hormone. It's a precursor to testosterone. It's converted into androstenedione, which eventually is converted into testosterone. Testosterone is aromatized into estrogen. Evidence has, however, accumulated for beneficial effects of DHEA on osteoporosis, both in postmenopausal women and in patients receiving long-term glucocorticoid therapy. In conclusion, the current results suggest that DHEA can improve postmenopausal osteoporosis by upregulating osteoblastic differentiation via the upregulation of the expression of osteoblastogenesis-related genes. DHEA has protective effect against osteoporosis in women after menopause through the intricate mechanism in osteoblasts, which DHEA is converted to estrogen through the aromatase activity.